All right, so today what we're going to cover biofeedback. Biofeedback, for some reason, it gets to be a little tricky. We'll go into that in a little bit. It's way simpler than what you guys, what historically that the students have wrapped their heads around. So, and then we're going to go through cervical traction. So we have, how many units do we have? 3 units in the back, 3 traction units. Yeah. So we're going to split up. Half the class is going to practice biofeedback while the other half goes in the back and we'll play with cervical traction, and we'll swap. And then next week we'll start on lumbar traction. So first up with biofeedback. Biofeedback is a broad term. All it is we're getting information about the body. Who's got a smartwatch? So that smartwatch gives you information about your body, heart rate, how many steps a day, maybe temperature, maybe respiratory rate, right? So all we're going to do, and others potentially brain waves on, maybe not in your watches, but on other forms. So the idea is just to bring conscious awareness of your physiological function. The way we're going to use biofeedback is there's 2 ways we're going to use it. 1, to relax a muscle that's in spasm. 2, to create a contraction when they're having trouble contracting that muscle. So this is basically the relaxing of a muscle that's in spasm. That's creating that brain-body connection to try to say, hey, this right here, relax this. And sometimes that's really valuable. The other one, instead of Russian stim, we tried Russian. They can't tolerate the type of electricity that's in it, the pain of it. Well, we can try biofeedback potentially to create that brain-body connection. So the tricky thing that we have is we've had a bunch of different forms of e-stim that are applied to the patient. This is just giving us information now. We're not turning the dial. I mean, we're going to change some settings depending on what we want, but we're using the e-stim machines just as an instrument to tell us information and to tell the patient information, just like the blood pressure cuff tells us information about their blood pressure. Pulse ox tells us information about their oxygen levels. This is just a tool to give us and the patient information. The machine isn't inputting anything into the patient. Okay, does that make a little bit of sense? Just like the watch on your wrist. So we're not measuring how much muscle contraction there is. We're simply measuring how much electrical activity there is in the muscle. So again, nerves are send electrical signals. So there's a lot of different types of units. We're going to use our good old Tower Chattanoogas for this, but there's a lot of portable versions of them. So there's no standard measurement scale. So when we're documenting it, we have to be specific to the machine we're using. But we can give feedback with either ourselves or our patients with light sound. Sometimes things light up, other times they beep, these beep. And what we as a therapist, the things that we can adjust is the sensitivity of these machines. So we can set the sensitivity really high so that if there's any form of electrical current causing a contraction, it'll detect it, or we can set it pretty not sensitive, and it's going to take a lot of electricity, a lot of electrical activity, and a lot of contraction to detect. So we'll look at that in just a little bit too. So again, the 2 forms that we're going to use biofeedback, either muscle relaxation or muscle activity or a contraction. So muscle relaxation, typically the unit is set to a higher sensitivity. As the patient improves, we can play with those intensities. Electrodes are placed together on the tense muscle. And as the patient improves, we can move the electrodes further and further apart. Now, the tough thing that we also have for us is, one, we have to have really good clinical knowledge of, oh, the rhomboids are exactly here, right? So if you want to get the rhomboids to relax, you got to place your electrodes on the rhomboids. It's not going to help if we're on a different muscle. So your clinical knowledge of your anatomy is going to be really important. The other thing that's going to be tricky for us is the pad size. So pad size, because we're not inputting any sort of electricity into the body, we're only reading the messages. It's the anatomy is going to dictate the pad size more than, oh, just go the biggest possible, right? Our whole rule has always been the biggest pad possible. Now it's, well, the pads have to fit the anatomy we want. Rhomboids relatively small. We don't have a lot of space, so we got to have pads that fit on that muscle. Other things we can do, other relaxation takes, imagery, breathing techniques. What were some of the, Brianne, you're shaking your head already. Like, I don't want to do that. You hate relaxing. Brianne hates relaxing so much. Don't get Brianne a spa day for a gift. She's like, what am I going to do there? I'll do jumping jacks while you. So what are some of the breathing techniques that we already know? Box breathing, 4x4, right? In for 4, hold for 4, out for 4. So yeah. Oh yeah, the secondary breathe in. Yeah, that's a good. Anybody remember the name of that? Forget the name of it. All right, we'll look it up. So any techniques that we know that are good to help a relaxing state that we can use in addition to this biofeedback. Now, hopefully, if we do our job well and the patient can cooperate with us, the treatment should only take 10 to 15 minutes to help relieve some muscle spasm, some of the voluntary muscle spasm. If your patient's Brianne, it's going to take a little longer. So. Now, muscle re-education, we're going to first start with low sensitivity. We're going to, any sort of electrical impulse in that muscle we want to detect. As the patient gets better and better, we can adjust the sensitivity to it. We're going to begin with asking the patient to perform a maximal muscle contraction. That's what we're going to set our target to. So we get to set targets to this so that when the patient does achieve it, we're going to get a flashing light or a bell beeping type sound to tell us that we did a good job. We're going to have the patient perform isometric contractions, 6 to 10 second holds, roughly 2/3 of the max effort. We can adjust all of the parameters should we need with the machine. And again, each unit has slightly different operation to it. So you're just, whatever unit's available to you, you're going to have to learn how to operate that. And then it should be just about 10 to 15 minutes just for that neuromuscular re-education. So again, this is, we're trying to create that brain-body connection again. For some reason, it's interrupted, and we're trying to restore it. Both in the muscle re-ed as well as the muscle relaxation. We're trying to get both of that brain-body to say, no, you can relax this muscle, or no, you can contract this muscle. So in a little bit, we'll play with these machines. Everybody brought their electrodes, right? So we'll play with those machines in a little bit. It'll take a little bit of playing around to get used to it. I think we have some portable units too. We'll ask Tony to break out. All right. We're going to cover cervical traction today only, and then next week we're going to go through lumbar traction as well. So here's our normal spine anatomy. Obviously, we have our vertebrae. We have the interarticular disc in between the two vertebrae. We have these holes here. What are these holes called? What is it? Intervertebral foramen. I call it neuroforamen. Anybody ever hear it called neuroforamen? Why is it called neuroforamen? Because a nerve exited. Yeah. So what's cool about these is that they can change their size. How do they change their size? These neuroforamen, their sizes change all the time. So when we flex, what happens? It gets bigger. When we extend, what happens? It gets smaller. How about side bend? So if I did a left side bend, what's happening to my right neuroforamen? Bigger. My left neuroforamen? Smaller. Yeah. So how about rotation? Yeah, I mean, Michelle's mad. She wanted to stick with those two. Yeah, so if I turn to my left, my right neuroforamen is opening, my left neuroforamen is closing. So getting a little bit smaller. So how else can the size, what else affects the size of these neuroforamen? If the disc becomes displaced, yeah, so we got this picture here. Yeah, if the disc gets displaced and it takes up some space. Yeah, all right. Anything else? Fusions. So typically what they do with fusions is they typically lop off. Whoa, look what happened there. They typically just cut off the back half of that vertebrae and throw it away. Maybe they put it somewhere else. I don't know. And then they put a bunch of rods in place. Not all the time. It's called a laminectomy. You've probably seen that. All they do is they just cut these pieces of bones off and take them away. Okay, now you don't have a neuroforamen to worry about. It's open. We just have those are pretty cool because you can just poke the spine. There's no spinous process in your way. You can just go, hey, you feel this? Degenerative disc disease. What that's a pretty fancy word. Give it a little bit different of a name. What's okay. So when this disc, when it's aging, it's losing water content. If this disc shrinks in height, that would obviously create a smaller neuroforamen. Good. What other things happen, anatomy changes with? Not osteoporosis. Osteoporosis is decreasing bone mass, but osteoarthritis. So with osteoarthritis, we also get bone growth, bone spurs, so if we just had a little bone spur that just started growing and impeding that space, there we go. So the kind of lump all term for any time that these neuroforamens or even the central, where the central cord is, the narrowing of that is called stenosis. So that's what it is. Stenosis is just narrowing. We got to figure out what for. So the two big reasons we're going to be looking at traction is disc-related issues or osteoarthritis type issues. Those are the big ones that we're going to be looking at. And all we're trying to do is just increase the space of that neuroforamen just enough so that the nerve isn't pinched. Who's maybe as we're driving here, sitting in traffic on the bridges, who, just puts a little bit of weight on their ulnar nerve, and then all of a sudden, 15 minutes later, you're still stuck in traffic and you're screaming, but your hands went numb, right? How many people felt that this morning or sometime recently? Right. So that's all that's happening here is there's this nerve hole is narrow for some reason. Born that way, bone growth, osteoarthritis, disc displacement, something is in the way, and it just pinches the nerve. But the problem is all of the symptoms that come along with that. And actually, if we went back to what Dan was talking about, this is the second bucket of pain that Dan was talking about, if you remember that. So here's a picture of that disc displacement, right? So the disc is becoming displaced, just encroaching in that neuroforamen. There you go. If it's displaced enough, and it takes up too much space in that neuroforamen, then you get those nerve-related issues. Here's our thinning disc, where you can see if we're losing that disc height, that neuroforamen can become smaller as well. Typically asymptomatic unless you were born with smaller neural foramens anyway, and now you got the two things. You're born that way and you have some thinning of the disc. And then you can see the degenerative disc disease, osteophyte formation. You can see these over here where that osteophytes are now encroaching into that neuroforamen as well. Broadly, also joint hypomobility. We can look at joint hypomobility for this. Different muscle guarding, common with tension headaches. So if we can't relieve these headaches some other way, then potentially traction can help us. Facet joint impingement. So facet joints do have a capsule that could theoretically become impinged within that joint space. Traction can be used to decompress those facet joints. So we can use standard traction, however, polyaxial auto traction, that's what we're going to be using in the back. Positional traction, manual traction are preferred due to the ability to isolate specific joints. So we'll look at some of those in a minute. So traction is just the force, that's the pulling apart. We'll look at mechanical, that's with our machine here and also our machines in back. Manuals, what this therapist is doing, giving a manual distraction. You're looking at that mustache, Brianne, is that what you're saying? And then we also have this gravitational. I've never had somebody do a great job with gravitational. So this is with a pulley system and a harness and a bag full of water, and you can change how much water is in the bag. Obviously, the more water, the more weight. So if we've got 8 pounds of water pulling down, that's going to pull up on that head by 8 pounds. If you need more, you add more water, you have more force. So distraction is the goal of traction. And again, we're talking about anatomy distraction, not, hey, look over there, right? So it's anatomy distraction. Although that can be good if potentially. So separation of joint without injury or dislocation is the goal. We'll look at some of this when we get to lumbar. So, excuse me. So traction, there's been a whole history of traction way back when Hippocrates started using it. Declined in popularity in the 17th century, not sure why. Increased in popularity in the 1950s due to James Syriacs and some newer treatment approaches. I also think when we create machines to do it for us and we get to walk away, I think that's always something that increases popularity. So systematic review published in 2017 noted that traction affects water diffusion and molecular transport, so important for intervertebral disc health, so that's good. Overall benefits of traction is suspect. Does it work, does it not? It's just like all of our other modalities, basically. Like, it's not a magic thing, but I have seen it work. This is one of those things that I've seen. Yes, definitely. My patients have definitely gotten better, and I can point to the traction being why. I've also had patients who come in with severe disc problems, hunched over, can't straighten up, terrible pain, put them on traction for 20 minutes, and all of a sudden they walk out and they're perfect posture with no pain at all. So I have seen this work. But just like with everything else, just because I've seen it work doesn't mean it works for everybody. And we just have to be, what's our whole career? Come up with a treatment plan, make sure that, what did you say? It depends. It depends is our whole career, right? Come up with a treatment plan. The therapist comes up with all of the evaluation techniques, comes up with a treatment plan. We try something, and then we measure to see if it's working, right? And then if it's not, we either troubleshoot within our treatments that we're doing. I don't care what it is, strengthening exercises, stretching exercises, modalities. I don't care what balance exercise. I don't care what it is. We can change within that treatment plan, or we can go back to the drawing board and say, this isn't working. So we'll go through a few ways of that. But overall, the traction research is flawed because of poorly defined patient population. You know, people with disc problems being lumped into the same research as osteoarthritis problem, that doesn't really make sense, right? So that's what it means, poorly defined patient problem. Also, if I did a research study with a bunch of 30-year-olds versus a bunch of 70-year-olds, well, right there, we've got a big difference in patient population. So patient population has a big part to do with why our research is flawed. Poorly defining objective variables, poorly eliminating confounding variables. So again, it's not magic, but it is something we can try. And for the right patients, sometimes it makes all the difference in the world. So precautions, joint hypermobility. We're talking about the spine hypermobility, pregnancy, especially the later stages of pregnancy. And I believe it's the first 3 months after delivery, because again, hormonally, what's happening? A bunch of hormones are set. Who is calling? Bunch of hormones are released to make all of the ligaments more and more lax for delivery of the baby. And those hormones, that ligamentous laxities last for, I think it's 3 months after. I'll double check on that. So pregnancy is a precaution. Acute inflammation, especially we're talking about the spinal area. Claustrophobia can be one of those precautions. TMJ, joint dysfunction for the cervical traction, because we are going to be placing, these harnesses around the jaw. So if they have a TMJ problem, then we could potentially be aggravating that. Cardiac or respiratory insufficiency, symptoms that increase with traction. That's probably a good rule for all of anything we ever do. Like, hey, if symptoms get worse when you do this, maybe think about that, right? Unstable blood pressure, contraindication, spinal infection, rheumatoid arthritis, osteoporosis. Again, osteoporosis is the decrease in bone mass. Spinal cancer, cardiac or respiratory insufficiency for inversion type traction only. Anybody ever see those inversion tables? Or sometimes not only inversion tables, but also anybody ever see like the boots with the bar that you hang on? So that's the other inversion type. Recent ophthalmologic surgery, spinal cord pressure due to central disc herniation is also a contraindication. So. For the inversion traction, it's because all the blood is rushing to the heart and lungs. So if we already have a heart and lung problem, we're increasing the blood flow to it, and gravity is always going to be forcing it there. Not a good combination. I don't remember why the precaution for cardiac insufficiency. I know for respiratory, especially with the lumbar traction, we are harnessing people and we're strapping them in real snug. So we're going to be restricting lung expansion for that. So I think that's why for the respiratory. I forget exactly for the cardiac.
The inversion traction upside down.
Yep. So here's a bunch of things that we're going to be looking at, and I've got some exact parameters for us to know. So what position do we want our patient in? How much poundage, how much force? The angle of pull is going to be really important. Static versus intermittent. Static is pull on them with 25 pounds and hold it. And intermittent is pull on them for 25 pounds, hold for 10 seconds, release for a few more seconds, pull back on for 10 more seconds. So we'll look at some of that in a little bit. Total treatment time, frequency of treatment, what equipment do we have or need? Do we want manual traction or positional traction? So for cervical traction, supine is going to be the most preferred. We can do some seated, although supine is most preferred, more effective for increasing posterior vertebral separation. So obviously we're going to be increasing that neuroforamen size with our traction in the supine position better than in the seated. So how much force do we want for cervical traction? Well, a human head weighs approximately 14 pounds. Generally accepted to produce elongation of the spine, we need 25 to 30 pounds. So that is the range we want to get to. Greater than that can cause muscle guarding, which that's not going to help us, right? So if we want to actually distract, more poundage, if that kicks on that protective mechanism and they contract, now we're not going to be getting that distraction. So less than 25 pounds, we're not creating the distraction. More than, we're going to kick on the muscle guarding and then prevent that distraction too. I will say the force in some research, the force needed to cause disruption at 5'6" was 120 pounds. So we are well below the amount of force it would take to actually injure somebody. So that's nice. That was on cadaver. What a fun study that was, huh? Let's grab a bunch of cadavers. Hey, Doc, I got a great idea. You got those cadavers still laying around? Because I want to try. I've been wondering about this. I think they just use the traction unit for their next patient after. Oh no, let me wipe it down real quick. I don't know. Yeah, no muscle guarding. Yeah. Yeah. I mean, so that's an even in an alive person, it probably takes even probably triple the amount of force to actually cause an injury because of that muscle guarding. So great. So Michaela's got a great idea. Jack it up. Anyway, stop thinking about cadavers on traction units. Let's get back to this. So I just want to say, so we're our highest that we're going to apply is 30 pounds of pressure. It took 120 pounds to create injury in cadavers. We're well below that, and that's something we can educate our patients on. No. We're well below where it would take 4 times as much force to actually create injury. So some question that cervical traction can reproduce lumbar radiculopathy in patients with a history of it. I think we can change some of our patients' positions. But it is something for us. It is something for us to consider. Just like with our stretching techniques, one of the questions is, where do you feel it? And if the reason is if they're feeling it in some place that they shouldn't, right? If they're feeling a pinch in the front of their hip and not the stretch in their hamstrings, then we can think like, okay, do I have to change this or not? So the rule is the least amount of force that's clinically effective. Great. That's what we would do. That makes sense. So overall, to increase the intervertebral space, it is generally accepted that 25-degree angle of pull is optimal. Although if you needed OA, right, that's at the top of the spine, right when the skull touches the cervical spine, if that's the location you want to work on, then we can have a 0-degree line of pull. We can choose static or intermittent. Static is going to be better if we want more muscle relaxation, or if we do want to have that facet joint stretching. Intermittent, more comfortable for pain relief, more comfortable overall, but also better for pain relief. The shorter the time, the on time, the more tolerance that the patient is generally can have. So if our patients are having some discomfort with this, then we can shorten up the on time. That can be something. So it's kind of similar to our rush in, right? I want to, if it's facilitation long enough to create a contraction, but I liked 8 to 10 seconds, but if they can only tolerate 4 seconds, maybe that's the best I can do for now, right? So, if we want facet distraction, we should have short and equal on and off time. So 10 seconds on, 10 seconds off. Disc herniations require longer on-off times, a 1-to-3 ratio. So 20 seconds on, 60 seconds off is what that would generally be. Treatment time, 20 to 25 minutes is going to be our general rule. So definitely for muscle relaxation, for degenerative joint disease, 25 minutes. For acute disc protrusion, no more than 8 minutes. Number of times per week is dependent on the type and severity of the problem, duration of relief from traction. Generally, the frequency is greater when the problem is more acute and when we have neurological findings. So if they're getting relief from it, yeah, we can do this a lot. Auto traction is traction force controlled by the patient through a footboard or other device, like this little bicycle pump here. It's fun. We have a few home units available to us. So this is a home unit. This is a different version of a home unit. Here's that water bag that goes over the door. I've never had a patient like one of those. It's always been a problem. It's the benefit of it is it's cheap. You can get those for $50 or less. These units, if my patient does respond to it, these are the ones I suggest they get. They're around $250. So there's a big price difference between the two of them. I've never had patients have success with the water bag type. I have had patients have success. If they respond to traction, they respond to this one. So, manual traction, experienced physical therapists can apply reliable traction forces over repeated trials. Decrease the number of alpha motor neurons in the upper extremity musculature. In Rhode Island, manual traction falls under joint mobilizations, which PTAs cannot perform. PTAs can perform grades 1 and 2, but this would be one of the things you can't do. So grades 1 and 2 are really small at the beginning of the range of motion. We're not creating new motion for it. Good for pain relief, good for synovial fluid production. You'll learn more of that in orthopedics. It wouldn't be with cervical, it would be with extremity joints. So what we're going to do is place the neck in positions that either enhance limited range of motion or maximize intravertebral space. Components that would maximally open facets include forward flexion, contralateral side flexion, and ipsilateral rotation. Will open facets on one side, however, close it on the other. So we went through some of that. So here's our big recap, the big contraindications and precautions, positions, line of pull, static versus intermittent with times for it. You like this? Good. This is Rose's chart. All right. So here's what we're going to do. We're going to play around with some biofeedback as a group just to show what we can do. And then about half of us are going to go in the back and play with cervical traction. Okay.